Welcome to the Fight Cancer with Dr. Prasad podcast, your source for the latest, most reliable, and research based information about cancers and their treatments. I'm a radiation oncologist, and every single day I have patients coming to me with lots of questions about radiotherapy. They're very confused about it because this is the information which is not very readily available online, and there are so many confusing sort of advices that people get. So let's deep dive into what is radiotherapy, how do we do it, when do we do it, why do we do it, and for whom do we do it, and what do we expect at the end of it. Now, first of all, what is radiotherapy? Radiotherapy is treatment of cancers with high energy X-rays or gamma rays or heavy particles. So from a simple perspective, we are targeting very high energy radiations into the patient's body onto the tumor and killing the tumor cells. The way radiation acts is very interesting. It does not kill the cells immediately. It causes something called as a reproductive cell death. Now, what's reproductive cell death is basically when the radiation goes and hits the cancer cell, it goes inside and damages its DNA. So it damages its genes. Now, that doesn't kill the cancer cell immediately, but when the cancer cell tries to divide and increase in size, that is when the cell dies. Now, this is a very, very important point for you to remember, because this is sort of helps you to understand why your doctor asks for certain scans to do at a particular time. So, tumors which are slow growing. So, for example, if you take tumors like a renal cell carcinoma, or kidney cancer, or a prostate cancer, which grows very slowly, when we treat these cancers with radiation, for all the cancer cells to die, it takes a long time because these cancer cells are dividing very slowly. So for all of them to die, it's going to take some time. But on the contrary, if you look at cancer cells which are dividing very fast, so cancers such as lymphomas or blood cancers, there are certain types of cancers in the throat or your mouth where we give radiation and the cancer cells will melt away immediately. They respond very well, they respond very fast. So the way radiation acts is it attacks the cells of the cancer and damages the DNA, and hence when the cell tries to divide, the cell dies. Now this is happening at a cellular level. It is not happening at a patient's body level. It's happening inside the patient's body. So what does the patient feel when they are on radiation? And the answer is they feel nothing. When they're taking the radiation, they actually don't feel anything. It's like when you go to do a chest x-ray, or your doctor may have asked you, you have cough, cold, whatever, you do a x-ray of the chest, you go and stand in front of the machine, they press a button and the image comes up. Radiation is exactly like that. You don't feel anything when you are taking the radiation. So it's a very, very simple, relatively simple procedure, no pain and no irritation happening at the time of the radiation. Now, your doctor has told you that you need radiation, or somebody whom you know who has cancer, the doctor has told them that this patient needs to take radiation. And that is when all the confusion starts. Okay, so I'm going to go step by step into this confusion. So first is, when do we give radiation to the patient? Now, radiation can be given at different points in time of the patient's cancer journey. And when I say cancer journey, what I mean is from the time that they got diagnosed till they receive different types of treatments and they get cured, or they may not get cured in some cases, unfortunately. So what happens in that journey? So radiation can be used in what we call as a radical setting, where radiation is used as the primary treatment. That is the only treatment that is being given. So for example, when you're treating cancers of the throat, where we are using only radiation as the treatment, no other form of treatment is needed. That is radical radiotherapy. In some patients, we do what we call as adjuvant radiotherapy or post-operative radiotherapy, in which case patient has undergone a surgery, for example, a tongue cancer patient or a breast cancer patient, where we give radiation after their surgery has happened to reduce the chances of this disease coming back. In some patients, we combine radiation with chemotherapy, and that chemotherapy is given primarily to increase the effectiveness of radiation. That is called as concomitant chemoradiotherapy. So radiation and chemotherapy given together to fight the cancer better. Now that is used in very common tumors, such as again some of the advanced throat cancers, in cervical cancer, cancers of the womb, and esophageal cancers, and many other tumors. The other form of radiation where we use is what we call as a neoadjuvant radiation, where the doctors are asking you to take radiation first, and after that they're going to do surgery. So typical example would be a rectal tumor, tumors of the fecal passage, or tumors of some of the food pipe, where we give radiation and chemotherapy first, shrink down the tumor, and then offer surgery to the patient. And in some patients, we do radiation as a palliative treatment. Palliative treatment is symptom control. So the patient's tumor, unfortunately, cannot be cured, but we are offering them radiation to control their problem. So patient may have severe pain because of cancer, patient may have some bleeding because of cancer, and the radiation is offered to control that. Now, one important thing to remember for all of us is that radiation is a local treatment. It is like surgery, where suppose you do breast surgery, you're only being effective in that area. So radiation is also being effective in the area that we are giving it. It is not acting throughout the body. In contrast, if you look at chemotherapy, immunotherapy, targeted therapy, hormone therapy, all of them are acting throughout the body. So radiation is a local therapy, and the other therapies are systemic therapies. So this is again an important point to remember, because when radiation is given locally, the side effects are also generally local. When you give chemotherapy, the side effects may happen in different parts of the body. So these are some of the important points to remember about when is radiation given. Now the next question that comes is, where do we give it? Which machine do we use? Which hospital do we do? And then the bigger question, what type of technique of radiation should we use? Now, over a period of years, different types of radiation machines have evolved. Now, all of this started around 130 years ago when William Röntgen discovered X-rays. He first found out that there are some strange rays that I cannot see, but they're there. And because there was no name for it, he called them X-rays, like an unknown rays, and that name sort of stuck. He discovered them in 1895, and immediately next year, they were already being used for treatment of cancers. So it's been almost 129, 128 years that we have been using radiotherapy for treatment of cancers. But the major advances in radiotherapy happened after the Second World War. So around 1940, 1950 was when the radiation equipment started getting better and better, and patients started getting better and better treatments. That also led to using radiotherapy in different types of cancers, and hence we started advancing the field of radiotherapy. Now, the common machines that are available for giving radiation, I will sort of split them up for you to understand, so that if you have confusion in your mind, which machine should I use, you will really benefit from this. Now, the most basic radiotherapy machine that is available in some of the hospitals today is what we call as a cobalt-60 radiotherapy machine. They have been fantastic machines for last 6-7 decades, and we have used them to treat and cure millions and millions of patients. But they are very basic. The treatment techniques that they offer are very basic, and the side effects are very, very high. I would strongly recommend not to get treatment on the cobalt-60 machines in today's day and age, because they will cause significant damage. It's like using a bullock cart to go from one place to another today when you have all the fancy cars that you can use. And so cobalt-60 is something I'm recommending not to use in today's day and age. So the other type of machines that we have are called as linear accelerators. Now, linear accelerators are the machines which actually do not have any radioactive material inside them. Cobalt-60 machines actually has a radioactive cobalt inside the machine, which is delivering the gamma rays. Now, the linear accelerators do not have any radioactive source. So the way they work is that once you switch the machine on, they generate X-rays, and those X-rays are then pointed onto the tumor and they get treated. These linear accelerators have evolved from 1950s till today, and it's been a fantastic journey. Now, broadly, again, they can be divided into what we call as photon linear accelerators and proton beam radiotherapy. I'm going to come back to proton beam radiotherapy a little later. Now on photon, again, you have different types of machines. The common machine that we have is called a C-arm linear accelerator. So the machine is shaped like a C, and it rotates around the patient, and the patient gets treated through that. A common example of that machines are, say, Versa HD, TrueBeam. These are the two most commonly available, or Edge linear accelerator. These are some of the common equipments that are available. The second type of machines are what we call as a ring gantry machines. They look like a CT scanner, and where the patient has to go inside that tube and get treated. So the common examples are tomotherapy, ethos, halcyon. Okay. Then we have some special type of linear accelerators also. Now there is a particular technique of radiation called as a radiosurgery. Now that radiosurgery, and I'm going to come back to what radiosurgery is. Radiosurgery can be delivered by certain machines. One of them is called as cyber knife. The other one is called as a gamma knife. Now there is a new machine called ZAP. Now, these machines have really nice fancy names, but they basically do the same thing. And the same thing can also, the radiosurgery along with cyber knife, gamma knife, and ZAP can also be delivered by the other linear accelerators that I mentioned. Okay. Now coming to proton beam. Now proton beams are a little different, and we are going to do a separate episode on proton beams with the proton beam experts, going into details about what is proton beam, when to use, how to use, and all of that. But proton beam does not use X-rays. It uses what we call as heavy particles. And the major advantage of proton beam is they will give minimum sort of side effects to the surrounding tissues. There are some big limitations of the proton beam also. They can't be generally used in tumors which are very large or areas which are very large. And of course, they're very expensive as well. Okay. Now this is about the machine. So which machine do we use? Now, if you are going to a radiation center which has the latest linear accelerators available, the difference between these machines is not very large as long as you choose the right technique. So let's go into what are the different types of radiation techniques available and which one should you choose. When I joined Tata Memorial Hospital in 2001, I was quite shocked because one of the first days, first few days, I'm in the OPD clinic, a patient of tongue cancer comes to us, and my teacher, Dr. J.P. Agarwal, tells me, Prasad, take a sketch pen, and gives me those marker pens, and asks the patients to lie down on the couch, and he marks few lines on the patient's face. So one line here at the upper part, one line here, one line at the collarbone, and one line here. And that's it. Radiation planning is done. The patient goes to the cobalt machine, and the technician there would treat the entire area in this square. So everything in that area gets full dose of radiation. The tumor gets cured, but patient has significant toxicity. Now this is what we call as a 2D radiotherapy or conventional radiotherapy. Again, it's been a great technique for a very long time, saved millions and millions of lives, but not suitable for today's day and age. So two-dimensional radiotherapy is a radiotherapy technique which we all should avoid. Over a period of years, we started using three-dimensional radiotherapy. So 3D radiotherapy came up where we started using 3D data. So using a CT scan to plan the radiation. Now 3D radiotherapy offered much better advantage over 2D. And so we started using the CT scans, and on that CT scan, we would sort of define the tumor that we want to treat, and we would put the radiation beam. So radiation comes like a ray. We would put the radiation beams from 2 or 3 different angles and treat that tumor. Okay, so this was 3D radiotherapy. And then a major revolution happened in the early 2000s. I remember I was in Tata Memorial Hospital, and it was 2004, I think, when we took our first patient for a path-breaking new technique called as IMRT, or intensity modulated radiotherapy, which completely changed the way cancer patients are treated. It completely changed how radiation is used in treatment of cancer. In IMRT, in sharp contrast to what we were doing with 3D CRT, we started delivering radiation from multiple different angles and also started changing the intensity of it. In 3D CRT, if I was using say four beams, so two coming from front, two coming from back, all four of them gave the same intensity of radiation. In IMRT, what we did, we started delivering radiation from 7, 9, 12 different angles, and each of those beam would give intensity in a very different format. So it is intensity modulated. The intensity was modulated. And why was it modulated? It was modulated to make sure that we give maximum tumor dose, but the minimum dose to the surrounding structure. So if I'm treating a tongue cancer, I'm giving maximum dose to the tongue, minimum dose to the salivary gland or the gland which makes our saliva, so that the patient does not develop dryness of mouth. So this was a revolutionary technique. In fact, when I was in London in Royal Marsden doing my fellowship, my professor, Professor Chris Nutting, conducted a study which even today gets quoted all over the world. It was called a passport study, where he proved that when we do IMRT for cancers of the face and neck, we actually significantly reduce the side effects and especially the damage to the salivary glands. Hence, the patients can eat better, speak better, quality of life is much better. So IMRT revolutionized things. After IMRT, we had IGRT, image guided radiotherapy. Now here, what we did is that we were doing this really fancy modulation of the radiation, but we were not sure where it is going. So image-guided radiotherapy added the facility of doing a CT scan just before we are doing the radiation. So patient comes in, patient lies down on the machine, and we do a CT scan. Then we figure out where the tumor is and make sure that the treatment is being delivered precisely. So IGRT, image-guided radiotherapy, basically made IMRT more precise and more accurate. In, I think, 2009, the new technique again came up called as VMAT, volumetric modulated radiotherapy, or also commonly known as rapid art. I was one of the first person in India to start using VMAT. I was at that time in Narnarodaya in Bangalore. I think there was only one hospital in Delhi that was doing VMAT, and we were the second one, I believe, first one in South India. Now VMAT changed the game again. What VMAT did is, instead of giving radiation from 7 different angles with IMRT, IGRT, it said, why limit us to 7? Why not do it in 360? So it started delivering treatment in an arc format where the machine will rotate completely around the patient. The advantage here was that we are able to deliver, split the dose into small packets and deliver it from very different angles. Hence, making sure that in the center, the dose is coming together on the tumor and the surrounding organs are getting less radiotherapy. So that's your rapid arc or VMAT. So the journey started with 2D, 3D, IMRT, IGRT, and VMAT and rapid arc. So these are the techniques which are most commonly used in the radiotherapy in today's day and age. I'm going to talk about now radiosurgery. Now, when you hear of radiosurgery, it sounds fancy, like surgery with radiation. That's like really cutting edge. And my God, what sort of magic is happening? And what sort of new technique is this? This is not a new technique. It's been around for a very long time. And it actually was sort of invented by a neurosurgeon, interestingly. What we do in radiosurgery is we use a very sharp beam of radiation, focus it on a very small tumor, and deliver very high dose of radiation. Okay, so instead of doing the radiation over 5 to 6 weeks, we just do it in 1 to 3 days or sometimes 5 days. There's a very high dose of radiation. In radiosurgery, typically it is a single dose of radiation that is delivered, high dose. The advantage of radiosurgery is that we are delivering high dose, so it is biologically more active, and we are able to sort of kill all the cancer cells more effectively. But it can be used in very selective patients. It can be used in very small tumors where we don't have to treat a lot of area. So I'll give you some examples. If there is a small brain tumor, maybe a breast cancer has gone to brain and we have to treat that. Or it could be a liver sort of a lesion which we have to target. Or it could be something in the lung, very small, less than 2 to 3 centimeters, that can be treated with radiosurgery. So not all patients can be treated with radiosurgery. Radiosurgery, when delivered by a linear accelerator, which can do all this IMRT, IGRT, rapid arc stuff, it's called as X-knife. When you use a specialized machine to deliver radiosurgery, which has a robotic arm, it's called cyber knife. And if there is another machine called a zap and gamma knife, where we are able to do radiosurgery only for the brain region. It cannot treat the rest of the body. Okay. But all these techniques, whether you use X, cyber, gamma, zap, they're basically radiosurgery, delivering high dose of radiation to a small tumor to kill all the cancer cells used in selective patients. Now, the next technique that I want to talk to you about is a very interesting technique, and I'm very happy to talk about it because I'm one of the pioneers of that technique in India. It's called as adaptive radiotherapy. Now, before we dwell into adaptive radiotherapy, let me first tell you how is the regular radiotherapy done. Okay, so patient first comes to the clinic. So suppose the patient has gone to a surgeon. Surgeon says, you need radiation, go and meet Dr. Prasad. The patient comes to me, to my clinic. I meet them, and my first question is, do you need radiotherapy? So I evaluate all their papers, I evaluate all the reports, and we say, okay, fine, you do need radiation to, cure your cancer. Then we discuss about how much radiation and where to give it and when to give it and for how many weeks to give it. Most commonly, radiation is given over a period of anywhere between 3 to 7 weeks. So it is given 5 days a week. For, say, if you are treating breast cancer, it could be 4 weeks. If you are treating tongue cancer, it could be 6 weeks. If you are treating a throat cancer, it could be 7 weeks. So it is given every day, Monday to Friday. Now, once the patient has met me and I said, okay, you need radiation, we need to start the radiation planning, then we discuss about which technique of radiation to use. I explain them the advantages and disadvantages of each of these techniques. Now, one thing to remember that all these techniques, whether we use IMRT, IJRT, VMAT, or adaptive radiotherapy, they are not essentially going to change the outcome, which means they don't have a big difference in cure rates. So cancer will be cured irrespective of which of these techniques that you use, but the side effect profile will change. So as we go higher up into the advanced radiation techniques, the side effects will gradually come down because the dose received by the surrounding normal structures will be lower. So the patient will have lesser side effects, but the cancer cure rates will be largely same. So the patient has come to me in the OPD and we said, okay, let's get on with planning. So then we call the patient for radiotherapy planning. Now in this planning, we make first a mold for the patient if we are treating face or neck. So if it's a brain tumor patient or a patient with a tongue cancer, mouth cancer or a throat cancer, we make a mask for the patient. Now this mask is made to ensure that the patient doesn't move while giving radiation, because if the patient moves, the radiation will go to the wrong area. So we make the mask and then we do a radiation planning CT scan for the patient. The planning can happen only on the CT scan. In some patients, we will ask for extra investigations. And many patients ask me, doctor, you're going to do a CT. Why do you want this PET scan and the MRI? Now, each of the scans will give us different information. So for example, PET scan will tell me where exactly is the cancer, has it spread to other parts of the body, what is the intensity of cancer. MRI will give me far more details. Suppose if it's a prostate cancer, we have to do MRI. If it's a brain tumor, we have to do MRI because we cannot see them clearly on the CT scan or even on the PET scan. So we do those scans and then the process of radiation planning starts. So where we on those radiation planning CT scans will define the areas that we want to treat and also the areas that we want to avoid. Say, for example, if I'm treating a breast cancer patient on the left side, I want to treat the left breast, but avoid radiation to the lung and especially to her heart. If I'm treating a brain tumor, I want to give as low dose as possible to the rest of the organs in the brain, especially the memory area called as hippocampus. So this is done while we do radiation planning process. And then the planning, then the treatment starts. Now, when the treatment starts, just before the treatment, we do a quality assurance test. So I've created a radiation plan. My radiation physicist has made a nice plan. I've approved it. We ask the system, ask the machine to deliver that plan onto an equipment, and we say, is the plan, accurate or not? Once that plan is accurate, the patient is good to start. So first day, the patient comes in. We explain them what's going to happen, what are the side effects, how do we manage them, what are the treatments that they need to take, and we take them onto the radiation machine. We all go in with the patient, we help them settle down onto the machine. Then we all come out. We can't stay inside the machine. Nobody can stay inside the machine. because there is there are high energy X-rays there. Okay. And then my therapist will do a CT scan for the patient. Our machine comes equipped with CT scan. All these machines have CT scan. That is the IGRT part, image guided radiotherapy. So we do the CT scan and then we say, are we giving the treatment to the accurate part or not? Are we targeting the right part or not? And then the treatment would start as per the plan that we have already made. The treatment will not take more than 4 to 5 minutes depending the technique that we use. So if it's rapid arc, it should take say 2 to 3 minutes. If it's IGRT, IMRT, it will take say 7 to 10 minutes. Okay, and in most patients, in some patients it takes longer time. Then the treatment will be delivered. Patient comes out, goes home. This will get repeated every day. And the radiation oncologist will meet you at least once in a month, if not more, to see how are you tolerating this treatment? Are there any side effects? Do we need to give any medications? Are there any other things that need to be checked? Okay. Now this is the flow for all the techniques, including IMRT, IGRT, VMAT, rapid arc. Now adaptive radiotherapy, as I said, is a game changer. It's very different. And what adaptive radiotherapy does is that the entire workflow is almost the same till the patient comes for the radiation treatment. We take them onto the CT scan. We do the CT scan on the radiation machine, and then the AI part or the artificial intelligence part of the machine takes over. Now, what this AI does, it identifies the tumor that we need to treat in the patient's body. It also identifies the area that we need to protect. Now, our bodies are such that they are continuously changing. So if I'm treating a prostate cancer patient, just above the prostate is our urinary bladder, which is filled with urine. Someday it may be more, someday it may be less, someday it may be empty, someday it may be full. Just behind that is our rectum. There may be gas in there, there may be stool in there. Now, what adaptive radiotherapy does is the AI part identifies these areas and says, oh, from the radiation planning CT scan to today, there has been a little change. And that little change, or more, a big change maybe, is going to impact the patient's treatment. Hence, it creates a completely new plan of radiation. Now, this new plan then is approved by the doctor. Then we do a quick quality assurance test, and then the treatment is delivered. So, what adaptive radiotherapy is doing is it is creating highly customized treatment for the patient, and not just for that patient, but that patient that very minute. So adaptive radiotherapy is a significant leap in technology compared to all other techniques. But adaptive radiotherapy cannot be used in all patients. The reason is, in some cases, it may not be needed. Like for example, in the brain, you may not need to do adaptive radiotherapy, or even you won't be able to do adaptive radiotherapy. And then there are certain areas where adaptive radiotherapy is highly recommended. So in the pelvic area, so all the CA cervix, CA endometrium, CA prostate, CA rectum, even head and neck tumors, some of the lung tumors, adaptive radiotherapy is beneficial. But it takes time. At standard rapid arc treatment, the patient may spend less than 10 minutes onto the machine. In adaptive radiotherapy, they will spend around 30 minutes on the machine. So we have to select the patients properly for adaptive radiotherapy. So if your doctor is recommending adaptive radiotherapy to you, you have to ask the doctor, doctor, are you sure my patient can tolerate adaptive radiotherapy? Not the side effects of the treatment, but the rigor of going through this process. So these are some of the treatment techniques that we use in treatment of cancers. Now, who does all of this? Who is involved in giving radiotherapy to the patient? You may feel your radiation oncologist, your doctor is the main person involved in this, and you're wrong. The radiation oncology team involves your radiation oncologist. You may have junior doctors. You have radiation therapists who actually deliver the treatment and play a very, very important role in delivery and making sure that there is precision and accuracy. And radiation physicists who actually generate the radiation plan, which is then approved by the doctors and then delivered by the therapist. We also have nurses, housekeeping staff, and many more support staff involved in your care. So when you are looking at options of where do I take the radiation, it's not just the doctor that you need to look at, or not just the equipment that you have to look at, but you have to make sure that the The team is overall good. The team is highly trained, and look for patients who have been treated earlier on that at that hospital. Ask them for their review. How was the team? How was the team work? Now, radiation work is very intense and needs a very, very highly engaged team. Because if the team is not working together, there are chances that there will be mistakes and errors, and the patients will eventually pay the price for it if there are any side effects. Okay. Let's talk about side effects of radiation. What are the side effects? Now, the side effects of any cancer treatment, especially radiation, can be split into two parts: the acute side effects, or the immediate side effects that the patient may face, and the long-term side effects that the patient may face. The immediate side effects generally would involve some sort of skin irritation. When we are using the advanced radiation techniques in head and neck regions, so if you are treating throat and oral cavity cancers or brain tumors, you do see some irritation of the skin. In breast cancer patients also, we do see some irritation. That irritation may range from slight itching to redness of the skin, in some cases darkening of the skin. Now, this is a temporary side effect. Once the treatment is over, it gets better. Okay. Now, in patients where we are treating the face and neck area, patients may also develop ulcers inside the mouth. And those ulcers can cause pain, irritation, sometimes even infections. But those are also temporary. So once the radiation is over, those ulcers will completely heal. Remember, radiation side effects will happen in the area where we are delivering the treatment, where we are treating. So patient who's taking prostate cancer treatment is not going to have mouth ulcers. Only if we are treating the mouth area, the patient will have mouth ulcers. If you're treating the abdomen or the tummy area for the patient, patients may experience sometimes loose motion because the intestines get a little irritated. If we are treating the lower part, where the urinary bladder is getting some radiation, the patients may experience slight increase in frequency of passing urination also. So these are some of the common acute side effects of the radiation. Now, most of the side effects will completely heal within 2 to 3 weeks of completion of radiation. Some of the side effects may become long-term side effects. Now, one of the common side effects is hair loss. Don't get worried, radiation does not cause hair loss on your scalp unless we treat it. So radiation will cause hair loss on the beard area for men if we are treating this area, or any patient where we are treating for brain tumor, the part of the brain where we are treating, that area may develop hair loss, and that hair loss generally is permanent. It cannot be reversed. In patients where we are giving radiation to the face and neck area, the patients may also experience dryness of mouth. So that may cause inability to take spicy foods. They may not get, a very good taste of food. But this, again, overall, generally improves with time, and the patients may get sort of better with time. They may not get back to the normal what they used to, but 70-80% improvement does happen. Rarely, where we have given radiation to the lower part of the body, patients may experience bleeding from the rectum or anus because of the radiation induced what we call as some abnormal blood vessels may get formed. Again, that is a side effect which can be easily managed with medications or a small procedure, endoscopic procedure. So these are the common side effects of radiation. Not all patients experience them, and some patients experience may less or more. The best is to ask your doctor what are going to be the side effects that you are experiencing. Also, please tell your doctor to give the medications in advance. If your doctor knows that you're going to have pain, then there is no point in waiting for you to develop that pain, then try to find the doctor and then take the medication. Get all the medications that you may need in advance. We give actually a prescription to the patients based on what are the side effects that they may experience at the time they're starting the radiation. So if they develop the side effect, they can take care of it. I'm going to wind up by telling you some myths about radiation. Okay. Now, these myths have been going around the circles for a long time, and a lot of patients ask me about this myth. The first one is radiation painful? Absolutely not. Radiation is not painful. You will experience no pain while taking radiation. But as I said, if you develop particular side effects, so for example, if you develop ulcers in the mouth, yes, it is going to cause pain. But if you take good painkillers with guidance of your doctors, that pain will disappear. Does radiation cause burns? Absolutely not. In some patients, the skin may actually develop irritation, as I told you, and in a very rare situation, the skin may peel off. But it's not a burn, just the superficial layer of the skin may peel off, especially if you don't take care of your skin as your doctor has told you. But that's a rare side effect, it's not very common. The third myth is people feel that when they take radiation, they become radioactive, and hence they cannot go close to children or pregnant women, and they have to stay separate, they have to use separate utensils. Absolutely not. You're not radioactive. When you take this radiation, the radiation enters your body and immediately leaves after doing the damage to the DNA. There's no radiation in your body. Okay, so absolutely no problem with you going close to your family and children. Fourth, radiation causes hair loss. Now, as I told you, hair loss will happen only if we are treating the area which has hair. Otherwise, it will not happen. Some people feel that their skin color will change permanently. Absolutely not. The change in the skin will be limited, and once the radiation is over, that color change will get better. Okay. Now, one side effect that patients are very worried about, and they're really almost scared about it, that if I take radiation, I will get a chance of developing another cancer because of radiation. Now, there's some bit of truth to that. When we give radiation, it does increase the chance of developing a secondary cancer, but generally we see the frequency of that happening, or the chance of that happening is probably around 0.5% over a period of 20 years. But if we don't use radiation to treat this cancer, which you already have now, then you may not be sort of around after 20 years. So we have to focus on treating the cancer that we have today and not worry about that small chance of developing a secondary cancer later. Of course, we need to keep follow-up and vigilance on this. So I would like to end by saying that radiation is a fantastic and effective way of treating cancers. It needs to be used judiciously. You need to select the right doctors, the right team, and the right hospital and the treatment machines to get better. Thank you for joining us today. I hope you find today's episode informative. Please feel free to ask your questions in the comment section and we'll get back to you with the correct information. Please do like and subscribe to the channel, but more importantly, share this information with people you care about. Join me in this fight against cancer.